KEQQ Radio, KEQQradio.com, 88.3. My name is Noah Chalai. Good evening to you. Happy to be here with you. What you're listening to, we are getting a live audio feed from the Grand Forks Empire Arts Theater in downtown Grand Forks, North Dakota. Basically, what it is the Students for Sensible Drug Policy are down there with a discussion panel. Now, they watched a short documentary put out by Prairie Public Broadcasting, Blue Cross Blue Shield of North Dakota, about the opioid epidemic in North Dakota. And our own Will Beaton, host of the Harm Reduction Hour, which airs KEQQ Radio at 7, I believe it's 7 p.m., so he would usually be live right about now. He's on site doing a live broadcast there. Will is a part of the Students for Sensible Drug Policy, and he's going to be bringing us a live report, and we are actually going to stream that discussion panel. So I am in contact with Will over the over cell phone here, and we're just waiting to hear from him when they are ready. If you're just joining us on KEQQ Radio, we have made some changes over the past couple of weeks. We are rebranding in such a way. We've also hired a radio imaging company to help us with that. So we are trying to become more and more involved with the community and bring you more and more content that matters from people that you work with, that you see, that you trust, that you live around right here inside of the community. So Will Beaton is a resident of Grand Forks. He grew up here, went to Red River High School, attended the University of North Dakota, and is now an on-air personality here at KEQQ. We're very lucky to have him and have him out there finding this important content and bringing it to you. This is the kind of thing that is we think is really important and a discussion that needs to be had. And Will has worked very hard over the past couple of years to get in contact with city officials and bring them up to par and bring them up to speed with what this discussion is and why it needs to be had. A discussion about drug policy, local drug policy, what we do about it, how we can help people, the solutions and resources that are available to those that are suffered from addiction. And so that's what tonight's panel is about, and it's an exciting precipice because it is the culmination of a lot of work, and so they have a lot of people that are out there that are willing to bring this to attention and get the people that have a voice, get the people that matter, and get them all involved. So we're going to punch in audio here and just see if they are ready to begin, see if this is the discussion panel has started.
What we need to do is work together to address that stigma, make people feel valued, make drug addicts feel valued. I remember Christmas Eve, I was using meth. I was running around town with my friends using methamphetamine. And I remember having the thought, I didn't want to be using methamphetamine or heroin, but there was no one I could turn to. There was no one I could tell my story to. I didn't feel comfortable telling my parents. I didn't feel comfortable telling my sober friends, my good friends. So what happened was I was left to engage in these discussions with people who were just like me, and the resource options in those scenarios are limited.
Okay, we're going to leave this audio up. So stay tuned. This is going on at the Empire Arts Theater in Grand Forks.
So one of the things that I did in my career is I was a crisis consultant for chemical dependency in a large hospital system. So we've probably, over the course of time, seen 10, 12, 20,000 people that we've done assessments with. And one of the things that we consistently see is that the level of care is not necessarily available to you at the time that you want it to be available. And that's one of the problems that goes with a sparsely populated state. It's not feasible to have treatment centers equally spaced throughout there's fields all over, but we can't support a treatment center in them. One of the things I think that's very important is that people realize that the only level of care to access treatment is not inpatient or residential. I think we need to be reaching out to our providers. I think we need to be letting the people that are in the know what's going on with us and asking the questions. In the hospital, we talk about the 48-hour window of remorse. Before people end up in recovery, they would tell us that they quit 1,000 times. 1,000 mornings they got up and said, I have got to be done. I cannot do this anymore. They quit with their friends, they quit with their family, they quit with, scrapbooking camp. They went somewhere and that was going to change it for them. They were going to quit. But the body's call to that addiction was not something that they were able to withstand. So I think we need to be able to step into those windows. We talk about 48-hour window of remorse. We need to step in right after I did something stupid, and we need to be able to access services. But I think we need to recognize that we can access on an outpatient level and have a great deal of success. Families, movies, we all go to treatment somewhere else, and Sandra Bullock goes across the pond in a canoe and everything is better. But the reality is that people are extremely successful accessing at an outpatient level of care, and we have access at those levels of care. So I think we need to be real about where the access is and how to best use it.
So Jennifer, are you saying that not everybody needs the same thing?
Not everybody needs the same thing.
Really?
Really.
Okay. I want to ask a question of Wendy, because there was a lot in this documentary about something that's called medication-assisted treatment, and that's an area that I think is sometimes confusing for the public, because I would say that the good news about the opioid crisis is that we actually have medications that help people get straight and clean. And so that's really lucky, because it isn't true of all of the things that are abusable substances in our society. So I think, Wendy, you really work kind of at the heart of that area. But one of the things that's difficult is that although medication-assisted treatment reduces the death rate in half at a year, and it doubles the recovery rate at a year. And as Jennifer points out, sometimes we have cancer drugs that we use that don't work that well. But even though that's true, there's still a lot of controversy about medication-assisted treatment, and some people believe that the medicines for opioid use disorder will somehow perpetuate, or they're a crutch, or that you see people arguing about whether that's the right kind of treatment, or whether traditional abstinence-based treatment is the right kind of treatment. And one of the points that's made in the documentary is that it's not a competition between traditional treatment and medication-assisted treatment. And I just wanted to maybe have Wendy talk a little bit about what she thinks about all of that, having sort of living at the heart of this, if you will.
There's an 85 to 90% relapse rate. Once people start the medication, you can always titrate down and get off of it. The studies suggest, of course, being on it for 6 months to a year and then titrating very slowly. But again, everybody became an addict for a reason, and so it's that time frame that people learn how to cope with all their problems and deal with their anxieties and all the underlying problems that they had previous to their addiction that actually causes them to use. So it gives people the ability to start thinking and rationalizing and working through their problems.
One of the things that I've read is that medication-assisted treatment is a platform upon which recovery can be built, and that it's certainly not a substitute. I think there may be some folks out there, because again, we have to individualize treatment, for whom recovery supports look very different, and some people need a lot more treatment recovery supports, so one size doesn't fit all. But I think one of the things that we in the field worry about is that the sort of competition between which model is the correct model sometimes gets in the way of actually getting the work done. So I guess it would mean that, Jennifer, who comes from a treatment background, and you as a medication prescriber, you're really not competing. You're helping people get so that their minds are clear and they're not craving and they're not doing crazy, stupid things to get drugs that get them in jail, so that they can work with Jennifer on how to learn to live differently. Is that right?
Yeah.
One of the things I think is important to remember is that people who have an external motivation to get well and stay well, counter to popular popular belief, tend to do better over the long term. If I have a support organization such as where I'm going for my medication-assisted treatment, if I have the legal system, if I have family impetus, those people do better in recovery because when the day is hard, they've just got one more set of tools and one more set of supports. I think we tend to believe that it needs to be an internal motivation, but it doesn't start out internal for most people. Most people it starts at external, and then I make it internal, and it's just one more part of that continuum of care.
In the documentary, Joe, who's one of the recovering people, has a great line where he talks about, I got on medication and I kind of put one foot in front of the other, and then kind of when I wasn't really even looking, my life turned around. It's not something that happens magically, I think.
So one of the things that we've heard is the treatment aspect from a formal standpoint, but we know that there are many social determinants of health. What have you found that has helped individuals recover, which may not be formalized treatment? What else is part of the program?
And I think it's an opportunity to help the audience know a little bit more maybe about something that's less familiar in the sort of the peer recovery realm so that they understand how that fits into all of this.
We don't work alone. We work alongside treatment providers. We work alongside medication treatment. And so it's just one more way to help people. Sometimes people don't need the full treatment, but they need that external motivator. And so they can come through our doors and get the help that they need. Sometimes people come through our doors and we refer them on because they need more than what we can provide for the peer recovery. We've had people who are waiting that timeline before they can get into treatment, and they start with a recovery coach and they build that relationship, and it works right hand in hand with their treatment.
What is different between treatment and recovery coaching?
For recovery coaching, we are not telling you what you need to do, and all of the plans are not the same. Instead, what it is you sitting down with your recovery coach and asking, what are your goals? What do you want to achieve? And then making a very personalized plan for you and what those goals are. We also are very data driven. So we are taking a recovery capital index, which is an assessment, and you get a number between 0 and 100. It doesn't matter where your number starts. Maybe you start at a 35 or a 49. After 30 days, you take that RCI again, and we want to make sure that your number is going up, and then that gives you the evidence that says, I am getting better. And so it's a nice way to prove that. We take it again after 90 days. And so we do a lot of different things. We have the ability to text message, leave messages, pre-program these. So maybe Wednesday night's your night that you've always gone out with friends bowling. You still want to do that, but you're in a recovery mode and you want to do things a little bit differently. Your recovery coach can pre-program a text message to you that hits your phone at 5 after 5 when you get off work that says, remember your goals, have fun, and have a great game of bowling. So it's a little bit different. Our people normally come in, our clients, once a week. You can go forever. There's no deadline for us, and we don't charge anything to the client that comes through our door. So anybody in the community, whether they have insurance or don't have insurance, can get free recovery coaching from us.
So Cal, can we put you on the spot a little bit here? In the documentary, there's a lot of discussion from the consumers about the use of medication-assisted treatment in opioid use disorders. I think that sometimes people really struggle with the idea that addiction may be a choice and that using meds is a crutch. And so thinking about that, what would you want to share with this audience? What would you want people to know about that? You have all of these people on the panel with you who are experts, but I'm kind of thinking you probably are an expert in your own right. So what do you have to say about all that?
Sure. I really like how you described Suboxone as a platform for recovery to happen. Suboxone for me has been an absolute godsend. I can't imagine where I would be without it. The real recovery for me began, just as in Joe Moran's instance, the recovery for me began right after getting onto the Suboxone. Within 3 months, I was able to forge new relationships and set new goals. gain employment and just have a normal life, have normal day-to-day activities.
Cal, what was different for you? What did it do that changed that for you?
It allowed me to feel well. Before the Suboxone, my goals and my life consisted of getting drugs to feel well, to have the energy to complete normal tasks, normal obligations, to go to work. I had to have some type of opioid filling my receptors in my brain, into my body, in order to wake up and get out of bed, to avoid the cold sweats, so I could sleep, the restless leg syndrome that occurs. I became physically dependent on opioids to function. So what the Suboxone did was it filled those receptors in my body. It allowed me to just go about my day and get confidence.
Does it make you high? I mean, does it, when people say, well, isn't that just substituting another drug?
No. Suboxone is a partial opioid agonist, whereas other opioids like OxyContin and heroin are full opioid agonists, and they produce euphoria. The Suboxone was very different. It didn't get me high. It just made me feel normal. I heard someone in the documentary say that line, that they just felt normal, and that's what it did for me. I did encounter a lot of stigma, even within, at NA meetings, there were opioid addicts that had, excuse me, there were opioid addicts that were not on Suboxone and were recovering in an abstinence-based style. And they also held that stigma, and even me, I kind of wondered, is it better to just do abstinence-based or do this MAT, this medication-assisted therapy? But I eventually resigned on the understanding that if it works, you do it, and it worked for me. It worked for me. Here I am. I have 1 semester left at UND before I graduate with a bachelor's in psychology, a minor in chemical dependency. I'm striving to do licensed addiction counseling at some point, and thank you. So yeah, Suboxone has provided me the opportunity to give back to the community, which is what I want to do. And earlier you had the question, what do you want the audience to know about people that have addictions? And I think what I want them to know is that we have shared values. Like, we have, even opioid addicts have the goal of giving back. They just don't feel well.
So with the prescribing, we've heard about the benefits. What are downsides that you've seen with prescribing, either side effects or things that the medication doesn't do that we'd hoped it would do?
For instance, at our clinic, we prescribe methadone. We also do Suboxone. The medication doesn't get rid of anxiety and all the underlying problems that people had before they started using. There are some minimal side effects, but when you compare them to all the horrible withdrawals and stuff like that, they're pretty minimal. Sometimes people have sweating, some sleepless nights, stuff like that, but for the most part, not a lot.
It won't take care of some of the other issues that people have or some of the other illnesses that people have. It plays a role, it plays a part, but we clearly need to also address the other sorts of issues that people are struggling with as well, where peer supports, treatment, et cetera, comes in.
Yes.
Wendy, while you still have that microphone, I wanted to ask you about, one of the things that happens, as I think Cal has mentioned, people don't choose to be addicts, but they sometimes make life-changing decisions, not necessarily in a good way. So a fair number of people with opioid use disorders, as Leanne Birch in the documentary talked about, end up in the criminal justice system. Just wondered if you have experience with that. And there was, I think, a call in the documentary about how do we help interface with the legal system, and how do we sort of maybe break down some of the barriers so that people who are incarcerated can get access to treatment or perhaps avoid incarceration. Do you have thoughts on that? And I see Jennifer shaking her head as well, so maybe you can both comment.
Yeah, when people have addiction to opiates, they fear more than anything else is the withdrawals. Like, it's life-changing, and they'll do anything to avoid it whatsoever. So they end up with a lot of criminal problems and stuff like that. And we found in our clinic that after people have started coming every day for dosing or even being on the Suboxone where they don't come quite as often, they get stable and then they realize they need to take care of all these other little issues. So we've had quite a few people actually come in and who have had warrants for whatever has happened in the past, and they have actually turned themselves in. We're able now to dose methadone in Cass County jail, so we'll go over every day and take anybody that's there their dose so that they won't have to suffer through the withdrawals. We're not able to do that yet here, and our clinic's actually trying to work with the jail here in Grand Forks and also on the Moorhead side. To start dosing, and we actually expect to start dosing there later this year.
So I'm going to say something kind of inflammatory here, and I would like Cal and maybe Jennifer to respond to this. Isn't it possible that people might need to suffer a little bit when they go to jail? And she's rolling her eyes at me because she knows I don't really think this, but I say that because I think there are probably folks who hope that the sort of negative experience would help people not do bad stuff and not get themselves in jail, so maybe we wouldn't need to go down that road. Can you help the audience with reaction to that?
Did you see me crack my neck? I was like, wow. Once upon a time, working in a hospital, a nurse asked me, how nice should I be to them? And I said, it hurts me that you asked me this question, and why do you ask? And she said, well, somebody told me they did it to themselves, so I shouldn't make it better. And we ended up having a really useful conversation about how painful this disease is and how hard I fight and how many days I don't know the answer. And I can't even go out and admit that I'm seeking an answer, because if I ask and I can't do it, what does it mean? So I deny to myself I even have a battle to fight. So I think kindness is our best point of entry in addressing the disease of addiction.
So that reminds me of what Cal said a few minutes ago, because I thought it was really sad when he described being out on Christmas Eve and not knowing where to turn. And so I guess in jail, we probably would give people insulin, if they had diabetes. And so, Wendy, you're saying we probably should be treating their withdrawal. And I think we've got another point of view here.
You have a sugar low when you're diabetic, you don't get punished. We deal with some people from drug court, and some of those people wanted to find community service for them to do, and, well, can we send them to your office and have them clean or do something? Well, we don't want to punish those people. We want to help them get well. And one of the things that we hear time and time again since we've opened our doors is when people come through our office and they've been there, they said, it makes me feel so good here. So we're really striving hard to remove that shame and stigma, so you don't feel like you need to put your head down and be ashamed, but you can come in and it's a part of being well.
I don't think this is something that we can necessarily arrest our way out of. That lady in the documentary mentioned that she had been in prison, she had been clean for 2 years, and upon release, within a week, she had relapsed into her old patterns. So on top of that, now she's been to prison, she's been labeled with these very punitive types of labels, being a felon, being a drug addict, making it difficult to find a job, just having all these different labels with a huge load of taboo attached to those labels. So yeah, I think we should approach it more medically as a disease. Medication is appropriate. If someone is released from prison and they don't have opportunities for employment, and their loved ones hold stigma about what a drug addict is, negative ideas about what a drug addict is, it's going to be similar to my meth Christmas Eve, where I don't know where to turn except for the people who are just like me, who are doing the things that I was doing.
And I think there's a lot of discussion about the medications and how to get more access. I talked to Cal before this, and he talked a little bit, as did the people in the film, about feeling lucky that they were able to get access to medications. It's such a striking thing to hear people say, I feel lucky to get medicine that helped me get well. We don't say that about other things. So can you talk a little bit about that?
So I think, historically, my father was a small-town family practice doc, and he said half of what he did was mental health, and he didn't know what he was doing. I think, yes, I sent me to medical school. Yeah, and actually I'm in the Grow Your Own program. My son's in psychiatry residency. But we're never going to grow enough psychiatrists. And, people really want to have one-stop shopping if they can. And it's always important for primary care providers to be able to treat the whole person. And a lot of primary care providers don't get the training, and so that's an area that the medical school and other training facilities are working on. But also, there's a movement to help primary care feel more comfortable, to get the supports, to get payment for treating individuals with more complex problems, which includes behavioral health issues. And then part of it also is being comfortable in being able to prescribe medication-assisted treatment. And so to be able to prescribe, if you're a physician, you can do 8 hours of training, and then that will allow you to be able to prescribe within a clinic up to 30 patients. And if you're comfortable with that, and after a year you're okay with doing that, you can increase that. Most of the primary care providers who are prescribing medication-assisted treatment don't treat that many, but they treat some. And then there are other specialties that individuals can actually prescribe even larger numbers in bigger clinics. The other thing is there was recently a law passed that allows physicians' assistants and nurse practitioners or clinical nurse specialists also to prescribe. And that's an additional 24...
And that's how we got Wendy.
Yeah, and that's an additional 24 hours of training. And so, but I think the important thing, and most people in primary care would tell you, they need the support. They need to have people to lean on, and they need to have reimbursement and time to be able to do that work. I think that's been a deterrent in the past was, initially it was stigma. They didn't want those people in our waiting room, and they take too much time. But now the people who have done this in primary care, I think to a person usually say, this is probably the most rewarding part of my job. But it's getting people comfortable and having incentives to be able to build that into your practice.
And I think weaving it into the treatment community as well. Part of what we are seeing with this epidemic is a manifestation of beginning to understand that recovery really isn't necessarily for experts, that regular people really have to define this. And I think that's actually one of the things that the peer recovery community has begun to help people to understand more clearly. And one of the things that we hoped to do, and obviously we have tonight, is with this documentary and with these kinds of conversations to challenge communities to see that they can have a role, that this doesn't have to belong to the experts or to the legal system, that people can help one another. And you've certainly heard stories about that.
Hi everybody, my name is Dean Christensen and I'm in recovery at Grand Forks. And if you'd like to not drink or use, you come do it with me, right? We'll do it together, right? Okay, my questions are, these drugs are not new. Methadone, 37 years ago when I went to treatment, they had Antabuse. These medications aren't new. They've been around for a very long time. And yet people still die at alarming rates, right? So it's got to be about getting it to the people, right? And my question is, how can we help, right? If I'm on the front line, so I help addicts all the time, right? But another way I can help is voting, right? So I'm under the impression that this is all paid for through Medicare and Medicaid for people whose parents ain't putting them through treatment with their insurance, right? So is that right? Is it paid through Medicare? So I can vote for people that don't want to cut Medicare so we can get funding so people don't die.
Well, we got this thing called mental health parity. You've probably heard about that a little bit. And I think that in general, our country's begun to be more enlightened about the need to treat mental illness and substance use disorders equitably with other disorders. So it's not legal anymore to not pay for these kinds of services and medications in the same way that other kinds of services are paid for. That's the good news. The bad news is our access to these things is that we don't have enough providers, we don't have enough treatment options for people to actually get access to. To your point, in Medicare and Medicaid, and actually in private insurance as well, treatment is paid, and the medications that are used certainly in opioid use disorder, which we're talking about tonight, those are reimbursed, those are paid for and recognized as parts of what healthcare insurance should pay. And I wondered if Dr. McLean might have something to say about the point you made about that these drugs have been around for a long time, because I think you're partly right about that.
Yeah, certainly the antabuse has been around for a long time for alcohol. For a while, that was the only thing that we really had. It's been since, I believe, 2000, at least, the waivers for prescribing buprenorphine has been fairly recent for some of the newer opioid treatment medications. Methadone has been around for a long, long time. We've had so much stigma that's starting to change. We haven't had enough providers. That's starting to change. But absolutely, and I think as the gentleman who originally asked the question, society has not been willing to address this. Some will argue that, well, the only reason that they're addressing it now is because there are affluent people who are dying now. I think that's been debunked in part, but there are some people that maybe are paying more attention. I think there is a shift in society, but I think going back to what the gentleman said too, what we're seeing is not just in addiction, but healthcare in general. There are many, many things that contribute to our well-being that have nothing to do with the healthcare industry, but we think that the healthcare industry should solve it. And I think his point was we all need to solve it.
To your point about voting, I think it's really important as a voter to let your legislators and the people who are running for office know that you think this is a really important issue, and because politicians, people in legislatures really do pay attention to what their constituents believe. And I think the more people who say this is important to us, this matters, you may not think that a voice of one matters, but I think that it does.
Can I make one quick comment? I think it's important in the continuum of care that is recovery that we recognize who's successful and why. And research tells us the single thing that is in common between people that stay in long-term recovery successfully is that they have a community that surrounds them that supports their recovery. And we keep asking, what does the community, what do? We make it safe to have the conversation. We make it safe to say, I need help. We don't encourage people to go out and have just one. We encourage people and we support them in seeking care, in getting care, and in being in recovery. And I think we stop talking behind our hands, and I think we have to become very open about the conversation, and I think we just need to make it safe to talk to each other and support people who are in recovery.
I'm going to give you Hi. I just wanted to say first, I really like the harms reduction stuff I've been hearing up there. That's like awesome. I love that. The recovery coach thing, I've heard of it, but I didn't know you guys were doing that much. I think that's amazing. I just spent about 9 years in the state and federal system in prison. I just recently got out, so I guess I'm always going to focus on the prison aspect. I did see in the video, it covered a brief thing about saying, I think one thing that stuck out to me was that the judges or whoever are sentencing people to prison so they can get treatment. I'm not sure if I agree with that. That's why they're sentencing them, but it said that. But then it's like so my issue, and there's no one really up here like from the prisons or anything like that in treatment, but I just am concerned because it's like if people are going there, it's so overcrowded that the treatment they're getting there is almost like a no child left behind for drug addicts. They're just getting passed through. I mean, same with like at the halfway houses and things. That concerns me. So then it's like the recovery thing. I don't know if you guys have like the resources to actually like go to like let them know as they're being released, hey, this is something we have, we offering it for you, and to like, I think it's a great idea to keep spreading stuff like that. And also I was going to ask about the medication in like the jails and stuff for the people with short sentences too, but you guys already kind of talked about that. And so mainly just like the prison aspect, but it didn't say much about on the video. It just had, Chris Meyer, who I'm not sure what his stance is, because a lot of people are getting, a lot of non-violent criminals are getting sentenced, and obviously he's a prosecutor or attorney, so I don't know really like what your guys' ideas are on that, I guess. I don't really...
I just want to clarify one thing. Leanne Birch is the person from the Department of Corrections, and when she made that comment about judges sending people into prison to get treatment, I don't think that what she was trying to say was that that's the right thing to happen and that that's what she wants to have happen. I think the point she was making is that judges are trying, like everybody else, to find ways to help people get treatment. And obviously I think most of the people on this panel would say that there probably are better ways to get treatment for folks than sending them to prison. Anybody have any additional thoughts on that?
One of the things that the First Lady has done is she mentioned it briefly in the documentary, but it's free through recovery. And so it's going to be working with both males and females coming out of the prison system to get them connected with a care coordinator so that they can have peer support, they can have someone helping them with jobs, with housing, to help integrate back into the systems out here so that you have that continuum of care that's been missing in the past.
The other thing I encourage people to do is, again, I was assessing people in hospitals, but I also used to work in the prison system, and I worked in the transition out of prison system. I would encourage, if there's any probation officers out there, if you could make it safe for people to tell you the truth about how their recovery is going. This is a very, very powerful position, and when I call a probation officer from the hospital and I say I got somebody here who desperately wants treatment, very rarely do I hear I'm going to revoke them. They say to me, what can I do for him and how? I think we need to remember this system is supposed to be designed to keep you out of prison after we have hopefully intervened on the substance use. Like if we can get you there and get you stopped. Sometimes, a client one time told me I didn't get arrested, I got rescued, and that really stuck with me because that was the moment in time their usage stopped. We got them treatment in prison, we got them treatment after prison, but it needs to be safe. This is a chronic relapsing condition. It's a lifer. So I need to be safe to go back and say, I need another run at this. Don't throw me back in prison, just send me back to treatment for a tune-up.
The medical director at the prison is working diligently to start a program. I believe they're working with Heartview to start either Vivitrol if someone's been in the prison system for a long period of time to help them when they get out, or Suboxone or other medications while they're in there to help in their recovery. And we're missing a huge opportunity there with that group of people. So they are working on it.
Hi, I'm Allison Brennan. I am a postdoc research associate for a regional rural development center, and I'm wondering what your thoughts are on the kinds of solutions that are going to work in rural communities where there are additional considerations and challenges, which I don't think I probably have to list. You probably know those.
No, that's a great question. And in North Dakota, it's particularly important. So some of the treatments, not necessarily the prescribing at this point because there are regulations, but some of the addiction treatments actually are being done via telemedicine, telehealth. That's one option. Another option that's really been working well from a prescribing standpoint has been a hub and spoke model, whereas a group such as Heartview that has significant expertise has partnered with Coal Country, a federally qualified health center, to help their primary prescribers work out in the field, out in the rural areas with individuals who need medication-assisted treatment. And that's a model they're trying to improve and expand within the state. Yeah, and Dr. Fausto just mentioned, we have a project going on right now that's a grant from SAMHSA called Project ECHO, and that essentially is helping individual prescribers and treatment providers across the state who want to learn more about opioid use disorders, medication-assisted treatment. We have subject matter experts from outside the state as well as within the state who are doing video every couple of weeks, and they're doing a brief training, didactics, and then they're doing case presentations that people can discuss, and then they're available for other sorts of resources. And so it's called Project ECHO. It's been used in many, many other issues, including, it started with hepatitis C, but it's expanded to everything you can think of. So we're doing that right now on medication-assisted treatment, targeting primary care providers in rural areas.
And one of the things that we're doing with that project is, on our team, we also have people who are experts in recovery and in treatment, so that they can, we can begin to help the rural providers partner with the treatment facilities who work around them and who are close by, and to develop kind of creative solutions like telehealth, other things, so that we sort of grow an organic network in the state where we raise the standard and the education about both traditional treatment and medication as well.
One of the other things that Face It Together is doing is we just signed a partnership with Shatterproof, and we will be creating virtual coaching. So anybody across the nation, actually, or any rural part of North Dakota, very similar to telehealth, but they can use their phone or a computer and have a virtual coach whenever they need it. So that'll be a great addition.
There's a question.
One more thing that we have available to us in 93% of the country is 211. I don't know how many of you are aware of 211, but it's like mental health 911. I don't need a fire truck, but I need somebody to talk to tell me how to address an issue. And they are doing a very good job of keeping track of where the little pockets of counselors are and people that can provide the different services. You can call 211 from virtually any phone. There's like a couple of, I don't know, by-minute phones where it doesn't work, but I don't, 235-SEEK, I think is what you call then. And I think we need to also remember that we have, in almost every community, we have a peer support group. We have the recovery communities, and I think we need to, again, make it safe for people to go to those meetings. I frequently hear in the hospital people say, well, I live in a town of 200 and I can't show up at the Lutheran Church on Tuesday because everybody will know why I'm there. And I think it needs to be safe to be there on Tuesday.
Amber, I know there was a question down here, or we have another one over there.
I work with grades 6 through 12 at my church, and I've heard a lot about how to help people post-addiction. How do we help them before it starts, or maybe at the very beginning stages, with that being a major problem with our youth here in town? I'd like to know how to help my kid if he needed it.
Cal, you want to take that?
Sure, that's a really good question. I think, so thinking about growing up and going through middle school, my drug education involved a lot of the DARE program. What I remember about the DARE program was a lot of scare tactics, a lot of scary stories, and I want to be careful not to bash this DARE program as well, because they were striving for exactly what we are striving for. However, those scare tactics, they played a role in my thoughts about my drug usage. For example, what I remember about this DARE program is a lot of horror stories. You're gonna smoke marijuana and you might kill people, or you're gonna do something really crazy. You smoking marijuana. You smoke marijuana, and you're gonna immediately be addicted to heroin. And when I tried marijuana for the first time, I realized that wasn't true. I had done it for a few years, and I would quit and stop whenever I wanted to. So that the information from that DARE program lost credibility in my mind. That's my experience. So I think what we need to do is, again, just speak very honestly about drugs. When I was going through treatment, there was this mantra that a drug is a drug is a drug, essentially meaning that all drugs are the same, all drugs are bad, And I knew that that wasn't true. I couldn't get on board with that statement that I heard all the time at every meeting. I think we need to make sure that we don't say that a drug is a drug is a drug, because here in this Diet Pepsi I have caffeine, a drug, which is okay. It's okay for me to consume caffeine. You know, I'm not going to have severe side effects from consuming caffeine. It's a drug. Tylenol, you know, they're all different. Each drug has unique addictive profiles and unique side effects, different pros, different cons, and we need to communicate all those things honestly.
So if we had about 3 hours, we might be able to answer all of that question. I just want to acknowledge that it's a really important aspect. I think in the documentary, the parents who lost their son talked about how important it is to start early and start educating children, and most importantly, educating parents. So I don't know that we promised all the answers tonight, because that's part of the prevention issue. And you know, those of us on the panel who have talked about this quite a bit talk about how awkward and difficult it is, because addiction isn't just opioids. That's what we're focusing on, but it's alcohol and other drugs as well. So, you know, part of the dilemma is how to talk about this in a state that's #1 in binge drinking in the country, and you know, the challenges we face with parents and other members of the public. So, Amber is our next person here. Yeah.
Mine is for the lady in the gray. You had mentioned about going to the jails to help when they have addictions and their withdrawals, and you said you give them methadone. Is that a temporary, or is that something that they'll have to stay on always then, or something? Is that like a similar drug then, or what is it?
So methadone is an opiate, just like heroin, except it's long-acting like Suboxone. So it builds up in your system over 5 to 7 days, and it'll last 24 hours, so you take it once a day. We can dose people in the jail if they've started our program beforehand. So if someone is in jail and they start going through withdrawals, we can't just go see them, but they have to be associated with us before they go in. So a lot of our people who have need to do jail time or turn themselves in for warrants are, because they are able to receive treatment within the jail.
But they're getting off. You're just kind of slowly weaning them. Is that what you're doing then? Or?
So opiate use disorder is a chronic disease. Some people will get off of it, some people won't. We look at it as harm reduction. So if someone's very successful being on it, then there's no reason not to continue it. We don't yell at the diabetic for continuing, you know, insulin because they have an occasional donut, or somebody who has high blood pressure, they continue their medications, just as an opiate addict may likely have to continue methadone or Suboxone. Some people, the hope is to get off of it, but not everybody will. So that's one of the big things with the stigma, is to make sure that we don't have expectations of these people, and that we say, you know, if you're on it forever, that's okay. You know, hopefully you can get off of it, but maybe not.
Got to punch in here real quick for legal ID. You're listening to KEQQ on 88.3 LPFM.
That idea a little bit, that somehow we would expect that success meant people stopped taking these medications eventually. And so it's only in the last few years that we've begun to recognize that for some people, that's probably not realistic. And so you hear people more and more talking about this as a chronic disease, the same way as rheumatoid arthritis or diabetes, where people may need continued treatment. And you've certainly heard people talk tonight about the need to maintain recovery, and that recovery isn't something that people they finally get it and then they don't have to work at it anymore. And so maintaining a sober lifestyle requires lifestyle changes and constant work. And for some people, it appears that it's going to require continuous medication over time. And we don't really know for certain why that is or how that's going to work out. But that's a really good question, because people struggle on that front. because I work for a health payer. I work at Blue Cross Blue Shield of North Dakota. And I've been asking that question for a long time because I've worked in addiction a long time. And I think one of the things that's reality is that this is a population for whom, at least initially, there's a lot of front-loading work. It's a difficult thing. It takes time and energy and investment. And primary care, it doesn't have a lot of any of those things right now because they're kind of ground zero for lots of things. And so our answer to that, at least in our organization, because we believe in this, is that we've developed reimbursement for physicians and mid-levels who are medication-assisted treatment providers for both their work and for the work of the care management around them to help with drug screens and pill counts and liaisoning with the treatment providers that they're working with, et cetera, because we recognize that there are a lot of altruists out there, but they have to keep the doors open. And so, our response to this is that you have to put your money where your mouth is and provide reimbursement for that. So we just actually got that up and running, and we have providers are now being credentialed with us so that they can begin to use those codes and bills for reimbursement. We don't like to talk about money, but money is a very important thing. So that's what we can do as a payer to help honor and recognize the need for that.
Yeah. And so what you heard here too is we're trying to expand the support to some of the providers and the training. What the state of Vermont has done is just fascinating. For every 100 patients who may be seen with substance use problems or behavioral health problems, they have dedicated 2 FTEs, full-time equivalents, a nurse and a care manager to each primary care clinic with 100 patients or more. So that's how serious they are about it. And you can imagine what benefit that would be to a primary care clinic. So that's how you get serious.
Like Texas has a database system where if said individual goes to this doctor and then they go doctor shopping, it shows up that, well, this patient saw this doctor prescribed this. The second part of this question is, the people that are prescribing opioids and potentially maybe getting people hooked on them, why are they not doing physical examinations on people that are always coming in getting these opioids?
So that's a great question. The first point, the database. In North Dakota, it's required that every prescriber sign up for what's called the Prescription Drug Monitoring Program, and you're required to monitor that every so often. Probably not often enough, but at least every 6 months if you're prescribing any medication that's a controlled substance. Yeah, and that's a new requirement. But so we have the Prescription Drug Monitoring Program here where you can check the box and go around probably to 25 different states and say, I know this person just came from Wisconsin and I'm suspicious, and you can actually see if they were doctor shopping. Now that doesn't tell you what they got on the street, but it certainly tells you what they might have been prescribed. So every prescriber, the physician's assistants and the physicians in the state of North Dakota are licensed under the Board of Medicine, and there are guidelines and requirements for them to actually do appropriate care. And if they don't, I know a number of physicians that have been, gotten their licenses removed. Board of Nursing has the same thing. The CDC, the Center for Disease Control, just came out with guidelines for appropriate prescribing of narcotics. And most of the healthcare entities in the state, the bigger ones, have really taken that to heart, and they've actually dropped their prescribing of narcotics by probably 25%, some of the bigger healthcare organizations. So there's a movement afoot. They're wanting to do the right thing, but there's pressure for them to do the right thing as well. There are still some lone prescribers out there who might be more problematic, and people are very good at finding them to prescribe, but the licensing boards are attempting to clamp down.
I have one more thought on that. When we're doing treatment with an individual and they will come forward to us and say, this is the doctor that, well, they call them their doctor dealers, right? And if there's a doctor that is essentially your dealer, and when they engage in the recovery process, we encourage and support them in writing a letter to the board or writing a letter to the doctor. A considerable percentage of the people that are using prescription medications that come through our program right to the clinics in, a 100-mile circle and say, don't prescribe to me, I have a doctor and I'm an addict. So again, we want to encourage people to take those positive intervention steps, but if there's somebody that's prescribing inappropriately and they're doing it, you have the power to turn that in.
So I think we probably ought to call it a night now. We've kept you over a little bit. We really, really appreciate you being here, and we really appreciate the questions that you've asked. I want to thank our panelists for their time and their wise answers and their involvement in this. I think that outside the auditorium, as you exit, there are cookies and coffee and water. So we would encourage you to continue the conversation as we go there. So I just would like to give the panel a hand as we exit. And I also want to tell you that the documentary that you saw is available. There's on the back side, I don't have it with me, the brochure that you got as you came in, there's a website, our Caring Foundation, the Blue Cross Blue Shield of North Dakota Caring Foundation website. You can go there and get the version of the documentary you saw tonight. It's free and available. We encourage people to take that, to take what you think about tonight, what you learned, talk to family, talk to people you work with, and continue the conversation. We believe that this is a problem that all of us together will solve. We're North Dakotans. We're good at solving hard problems and when we put our head down. So we appreciate your involvement. Thank you very much.
Again, you're listening to KEQQ on 88.3 LPFM. That was the opium crisis. There's a discussion panel that's happening downtown right now at the Empire Arts Theater. And as far as I know, KEQQ Radio is the sole provider of that broadcast. I don't think there's anyone out there that is bringing a live coverage of that. And so we were happy to bring that to you both on the air at 88.3 and on KEQQradio.com. The program that usually airs at 7 p.m. is Mr. Will Beaton with Harm Reduction Hour, and his program will be back next week at 7 p.m. where they reduce harm in society by talking about sensible drug legislation control. He frequently has Cal, who you heard on there, as a co-host, and so perhaps they'll be in studio next week. We were talking about doing that. We'll see if it actually happens. Just a reminder, KEQQ Radio is rebranding itself, kind of reinventing itself, so to speak. We've got a radio imaging guy that's coming on to help us do that, take care of some of that stuff. You'll find a whole new website at KEQQradio.com, as well as a new streaming embed. Works on iOS, macOS, Android, Windows, Linux, any operating system that you can think of, any device you have. We're here to serve you 24 hours a day, 7 days a week, 365 days a year. The next live program is going to be Dr. Chalaya with the Otter Health Program at 6 p.m. tomorrow night. He'll be taking your calls live. Again, that number 1-877-347-0011. That's 1-877-347-0011. And you can call him, ask him questions about your health. He'll give you the natural answer, how you can cure 85% of diseases without any medication. We're now going to return to our regular program, and we'll see you tomorrow night, 6 p.m. for our next live program. Again, you can catch my show, the Ask Noah Show, which airs every Tuesday night at 6 p.m. Find out more information about that at AskNoahShow.com.